Welcome to your overview of cognitive behavioral therapy, brought to you by allceus.com. In this course, we're going to learn how to differentiate cognitive behavioral therapy from other therapies, identify populations for whom CBT is appropriate, identify 3 CBT techniques that you will use with your population, and learn how to increase motivation using cognitive behavioral therapy. A cognitive behavioral approach treating cocaine addiction is the useful adjunct text for this course. It can be downloaded by clicking on the hyperlink below. There are certain assumptions with cognitive behavioral therapy. Substance abusers are deficient in coping skills, choose not to use those coping skills that they do have, or they're inhibited from using their coping skills. Cognitive behavioral therapy helps clients recognize the situations in which they're likely to use substances, find ways of avoiding those situations, and cope more effectively with the variety of situations, feelings, and behaviors that they encounter in daily life. There are some core elements of cognitive behavioral therapy: functional analysis, coping skills training, and relapse prevention. The functional analysis identifies the antecedents and consequences of behavior, which serve as triggering and maintaining factors. We'll talk about this a little bit more later. There are a lot of reasons for cognitive behavioral therapy. It's structured, goal-oriented, and focused on the immediate problems faced by the person. Why is this important? Well, most people don't come to treatment until they've got some stuff going on in their lives. A lot of people want to fix whatever's broken or not working right now. That's where their motivation is in the present. They're not interested in talking about what happened when they were 8, 10, 12. CBT helps them focus on identifying how their past is impacting them now, change their cognitions, and change their behaviors in order to behave and act more usefully or healthfully in the present moment. CBT is flexible and can be individualized for a wide range of patients, settings, and formats. CBT can be used with adolescents, it can be used with adults, and it can be used with elders. It can be used with people of varying cultures. It can be used with people with varieties of mental and physical disorders. It can be used in hospitals, in phone counseling, in e-therapy, in group and individual settings. It is compatible with a wide range of other treatments, including psychopharmacology and exercise, other medications for physical health issues, and support groups. Its broad-based approach encompasses several important common tasks: motivational enhancement, getting somebody motivated and keeping somebody motivated to do the hard work that they need to do, functional analysis, and change reinforcement contingencies. Functional analysis, again, is looking at what triggers the behavior and what rewards it once it happens. And changing reinforcement contingencies means that we change the reinforcer. Instead of alcohol being pleasurable when you drink it, you can take certain medications that make you want to vomit when you drink it. We provide skills training and coping skills. Now, in a strengths-based approach, we say, what have you done in the past that's worked? Even if it's only worked a little bit, we can enhance it, instead of trying to reinvent the wheel. Application and rehearsal. In group, we want to talk about how might you have used this particular skill in the past? How might you use it in the future? How did you use this skill last week, and how well did it work for you? Were you successful? If not, let's talk about why not and maybe make some adjustments. And we need to enhance social supports. We know that social supports are crucial to long-term sobriety, stress management, and recovery from a variety of physical and mental health issues. CBT is generally not appropriate for those who are psychotic or have uncontrolled bipolar disorder, if they have no stable living arrangements or are not medically stable. You've heard me talk in many other classes about Maslow's hierarchy of needs. A starving, sick, homeless person doesn't really care a whole hill of beans about working on his self-esteem or choosing a more appropriate coping skill. He needs to have food and a safe place to stay and be somewhat healthy before he can focus on those things. So we need to make sure people are getting their basic biological, physical, and safety needs met before we start approaching some of the more abstract stuff. Now, I know some of you are going, well, if they changed their behaviors and they weren't so negative and using alcohol and drugs, then they'd probably have housing. That's true. So we have to take the person where they're at and see what we can work on to help them really be able to focus on the bigger things. Somebody who's homeless and using alcohol, drugs, etc., probably needs to be in residential treatment for a short term so they can learn how to change those behaviors in a stable, safe environment. CBT focuses on understanding the determinants of behavior in the context of the patient's daily life. Why are you doing this now? What's the benefit? Skills training is most effective when patients have an opportunity to practice new skills and approaches within their daily routine. For example, when things irritate somebody, if they're practicing on self-soothing and calming themselves down by counting to 10, you want them to do that, and then maybe even log it in a journal. Not this whole long dissertation, just child back-talked, I counted to 10, and did it work? Did it reduce my anger and frustration from a point of not being able to deal with it to something that was workable? You're not going to have a magic fix. There's no magic pill where they do something and all of a sudden it's like, oh, well, I should have been doing that my whole life. If you can get them to reduce their distress from a 5 to a 4 or a 3, that is major progress. And it's important to discuss new strategies with the therapist. It's not one size fits all. The way somebody does something may work really well for Jim Bob, but not for Sally Sue. Journaling is a prime example. Didn't keep a diary when I was 6, 12, not going to keep a diary now that I'm a whole lot older than that. I'm not somebody who can sit there and write prose. I will keep lists. I will jot down things. So when you're asking somebody to keep a journal, if they seem to be resistant, ask them what might work for them or what they might be willing to do. Not everything's going to work for everybody. So it's important to work with your client to find out what works, because that's what's going to be reinforcing, which means that's what he's going to keep doing. In the initial session, you want to explore the reasons the client is seeking treatment and capitalize on those reasons. This is increasing the motivation, not saying, well, you're coming here today because you say that you're depressed, but I see this substance abuse going on and I really think we need to focus on that. No, the client's there because they're depressed. Yeah, overcoming the depression is going to involve not drinking so much, but we want to focus on the issue that the client is presenting with, because that's where their motivation is. We can work on increasing motivation for the other problems as we go through treatment. You want to identify the extent to which the motivation for treatment is intrinsic rather than influenced by external sources. Are they there to change because they're sick and tired of being sick and tired? Or are they there to change because their probation officer says so, or their wife's going to leave them if they don't change, or their doctor says they're going to die if they don't stop doing something? What is the internal motivation for them? Help them figure out why they want to do it for them and why is it meaningful to them. Other areas of concern that the client and significant others may have about substance abuse or other behaviors. So you want to ask the client, you came here because of depression or substance abuse, but I'm wondering if there are other areas of your life that are not going quite so well either. We might want to look at all of those, because as you make a positive change in one, you're probably going to see positive changes in the others. So we want to make sure that we don't miss anything. This is a non-threatening way to approach it, but we can also get an idea about how the negative behaviors are impacting all areas of the person's life. We need to identify situations in which the person drinks or uses excessively if they're presenting for substance use, or situations in which the person tends to get really depressed if they're presenting for depression, or anxious if they're presenting for anxiety. Somebody who's depressed may get really depressed on holidays, or if it's been cloudy and dreary and miserable for 3 days. Or there may be some other precipitating factors that you can look at and go, okay, well, that makes sense. We need to try to reduce that or counter it in some way. And we need to identify the consequences the person experiences from the negative behavior or feeling state. What are the consequences of being depressed? Why does it bother you? Why does it not bother you if it doesn't bother you? Cognitive therapy assumptions include the fact that the client can be educated to approach problems rationally. The 3 major steps in this process include establishing a rapport and educating the client about the cognitive model of therapy, the fact that changing thoughts can help change the way you feel and the way you act. The client educates the therapist about what's meaningful to him and the nature and extent of his problems. We know the technique, they know themselves. Neither one of us is going to be successful if we don't form a partnership. The therapist teaches cognitive techniques by having the client describe prior stressful situations and helping him apply techniques to those situations in session, and then asking him to apply the techniques between sessions and discuss it when he comes back the next week. Now, some of the things that we face with most of the people who present for depression, anxiety, substance abuse, your general Axis 1 stuff, is the fact that a lot of them have very irrational or disturbed thought patterns. Some of the most common irrational thoughts have been identified and are listed here. You must have love, approval, and affection almost all the time. Okay, must. You must, and almost all the time. Now, what happens if you don't have love, approval, and affection almost all the time? Is the world going to end? Now, do you have to have love, approval, and affection from yourself, from your higher power, or from others almost all the time? Depending on people's spiritual belief system and everything, they might be able to find comfort in the fact that their higher power loves them all the time. They might be able to develop a sense of self-confidence and self-esteem in which they can love themselves almost all the time. We can't count on people to love us almost all the time because we can't control other people. And they've got issues and they've got stuff and they may just have a bad day or they may just not like you. But does that mean that you have to let that negatively impact you? That's their stuff. In order to be worthwhile, you must be competent at everything all of the time. Now really, would we ask our kids to be competent at everything all of the time? No. So why would we ask ourselves to be competent at everything all of the time? When I was going through doctoral school and doing my dissertation defense, One of the things that one of my best friends told me before I went into my defense was they are going to keep asking you questions until you say you do not know, because they want to know that you know your limits. They want to know that you know you don't know everything. So don't say you know things that you don't know, which made a whole lot of sense. Even with a PhD, you're not expected to be competent at everything all of the time. I'm certainly not a brain surgeon. People who make you feel bad are evil and should be punished. Okay, we can all have that fleeting thought once in a while. But in reality, number one, do people have the ability to make you feel bad, or do you choose to feel bad? Are they evil? Well, maybe, maybe not. In reality, are they going to get punished? Probably not. So if they are evil and they should be punished and that doesn't happen, you're going to be disappointed. If I don't get my own way, awful things will happen. Well, again, every once in a while that may be true. Most of the time, it just means you're not getting your own way and you're angry about it. What's the worst that's going to happen if you don't get your own way? Unbearable misery comes from external pressures. Again, this is a choice. Is your self-esteem externally controlled or internally controlled? If something is dangerous or fearsome, you can't help but dwell on it. We have a choice. Yeah, it's going to come into our minds. That's anxiety. We have this emotion for a reason. It's to kick us in the butt and make us get up and do something. So if something is dangerous or fearsome, it might be kicking us in the butt to get up and get out of the way, or to do something to control the danger level. It's easier to avoid than face life difficulties. That's true in the short term. In the long term, avoiding life's difficulties creates much, much bigger problems. Have your clients look back at when they've avoided life's difficulties and see how many times that's ended up with a positive resolution. Your past must determine your feelings and actions today. Well, your past does make you who you are, but you have a choice in how to perceive that. People who were victimized in their past can choose to be victims, or they can choose to be survivors. People who were rejected in the past can choose to feel like rejects and create a self-fulfilling prophecy, or they can choose to be okay with themselves and find a better fit. And it's awful if you don't find quick solutions. Well, yeah, again, I tend to agree that sometimes we can feel that way. But quick solutions aren't necessarily the best solutions. And in reality, what's the worst that's going to happen if you don't find a quick solution? Would you rather have the quick one and have to do it again, or wait until you find the correct solution and be done with it? Now, in addition to those cognitive distortions that we just talked about, there are some others. Arbitrary inference means drawing conclusions without sufficient information, such as thinking your husband's having an affair because he comes home and he smells like a woman's perfume. What other things might have happened that could have made him smell like a woman's perfume? Could he have been in an elevator with someone who had way too much perfume on who rubbed up against him? Could he have been walking through the mall and accidentally gotten spritzed by a perfume tester? There are different reasons why this could have happened, but just assuming that he is having an affair because he smells like woman's perfume is probably a big leap unless you have other information. Another example is assuming plane travel is dangerous. Well, yeah, we hear about plane crashes, but we don't hear about the deadly car crashes that occur every day. So assuming that plane crashes and plane travel is more dangerous just because, we hear about it more, isn't accurate. That's just drawing a conclusion based on our perception of what happens. We need the information. Selective abstraction means seeing only what you want to see or what you don't want to see. Now, seeing only what you want to see, like when you're first in a relationship, you see all the good in somebody, and you ignore their annoying little habits. After you've been married for 20 years, you forget the good, and you see all their annoying little habits. Selective abstraction means not seeing the whole picture, only focusing on the good or the bad. Overgeneralization means generalizing things about one situation to all similar situations. For example, if you're a student and you fail a test, saying, "I'm stupid." Well, no, you may not be good at algebra, but that doesn't mean you're stupid all around. Making sure that we don't have self-deprecating thoughts that are generalized is really important to helping people improve their self-esteem. They can recognize that they're not good in certain areas. I'm a lousy car mechanic. I know it. I'm a lousy painter. I know it. And I'm okay with that. I'm good at a lot of other things. Personalization means everything is about you, being very egocentric. Everything's your fault or a personal attack. It rains. It's your fault. Somebody's having a bad day, kind of grumbles at you as they walk by. It must be something you did. No, people just have a bad day and grumble, and it rains. People who personalize everything tend to really rely on other people to validate them and give them those kudos. They're people who can't validate themselves. So when they personalize things that are negative, then it really sort of cuts them to the core. And polarized thinking is all or nothing. You're either good or you're bad. I want you on my team or go away. Now, in addition to our cognitive distortions, or to compound it, if you will, we have some basic emotions: anger, fear, and grief. Now, fear, as we talked about earlier, anxiety, is one of those emotions that's designed to kick us in the butt and make us get up and either fight or flee. Now, we have 6 basic fears: rejection, isolation, failure, the unknown, loss of control, and death. When we get afraid, when something happens, we have this fear reaction, and we have all these automatic thoughts. And then we either get angry, or we get afraid and flee. Okay. Unfortunately, a lot of people's automatic thoughts are overgeneralized or magnified or characterized by distortions, so they tend to be a lot more fearful or a lot more angry about a lot more things than they really need to be. Rational Emotive Behavior Therapy, REBT, helps people identify their beliefs that led to their emotional reaction and really look at the validity of those cognitions and change them to make them a little bit more rational. So why is grief on here? Well, because grief is a nice mishmash of a lot of things. Denial followed by anger. Remember, anger protects us from fear. Generally, we grieve things that we have lost. Now, it can be loss in terms of a death, loss in terms of loss of control over something, loss in terms of failure, or loss in terms of rejection. We need to grieve our losses. Come to terms with the fact that we don't have it anymore, whatever it was, and figure out how to integrate that into our lives and move to acceptance. It's important for counselors to realize that people need to grieve a lot of things that are not your typical tangible losses. So if someone seems stuck, we need to ask ourselves, what losses did they have? People who were in foster care as children didn't have the parents that they wanted. They didn't have the fairy book mom and dad. And they grieve that. They feel like they should have had. Well, they didn't. So now they need to deal with the fact that that childhood dream or concept has been shattered. Real uplifting PowerPoint, isn't it? But these are the things we need to help them realize, because it's hard to let go of some things until people have acknowledged, yeah, you didn't have a good childhood, or you didn't have any childhood at all, and that sucks, and it's not fair. I can't take that back, and I can't make it fair, but let's figure out what we can do now. In order to get people to do something to change, we need to increase their motivation, because change causes crisis, and crisis causes change. It's hard work. So we need to get people to be committed to this change. And in order for them to be committed, there has to be enough challenge in it that they feel like it's worthy of their effort. But it can't be overwhelming. They need to feel like they've got control of the situation and that it's a winnable or a doable situation. One of the things that we can do in order to increase commitment is to engage people in decisional balance exercises. We have them look at the benefits and drawbacks of staying the same. Yep, there's benefits and drawbacks to both, because you wouldn't be staying the same if there weren't some reinforcers. And we have them look at the benefits and drawbacks to change. Yes, there's drawbacks to not being depressed anymore. And the first time I say that to patients, they look at me like I've got 3 heads. But you know what? When you're not depressed anymore, you don't have an excuse for not getting some things done. People don't take as good a care of you. You have to take care of yourself. People aren't sort of fawning over you, if they did. Now, for some people, they didn't have a lot of reinforcers for their depression, so they're pretty motivated to get it to change. And as soon as the behaviors, as soon as the medication starts kicking in and they have a little bit more energy, they're motivated to do the next thing to start feeling better. But if you have someone who seems to be very resistant, then you might want to look at what's motivating him or her to hold on to that depression or anxiety. Maybe they're afraid of success. Interventions, the key ingredients. A functional analysis. What signals the person to do the behavior? If they're going to use drugs, what sort of things trigger them to use? Their breathing, the street they're on, the time of day, having money in their pocket. There's a lot of different things that can trigger drug use. Identifying what those are. We know what the reinforcer is. It makes them feel good. The functional analysis would attempt to eliminate some of the things that trigger them to do the behavior. And if we have the ability to make it not so rewarding through medication, usually, then we will do that. Methadone is a wonderful way of doing that for people who are addicted to opiates, because you can't get near the rush or the high, I guess, off of the methadone as long as you're taking it as prescribed, and you can't get any more than you have. But individualized training in recognizing and coping with cravings. What causes you to start craving? Managing thoughts about substance use or thoughts that maintain your anxiety or depression. Problem solving. That's one that people get stuck on, because a lot of people have felt disempowered. They don't know where to begin to solve problems. So let's start at the beginning. And we need to help them reward themselves for small successes. Planning for emergencies. If you're triggered to use substances, if you start to feel really depressed, maybe your dog died. You know, there are going to be things that make you legitimately depressed. So what do you do when that happens? Recognizing seemingly irrelevant decisions. These impulsive decisions that we make that, whatever, I can take this way to work or I can take that way to work. May seem irrelevant, but if that way to work happens to take you down by where you used to buy drugs at, that's not so irrelevant now, is it? That's your subconscious saying, I want to go there. And we need to teach refusal skills. Refusing drugs, and also refusing to let people make us feel bad. We have the ability to refuse that. We can say, no, sorry. An examination of cognitive processes related to the behavior. John was in the car. John got cut off in traffic. John decides to speed up, flip off the driver who cut him off, and then, in turn, cut off that driver. So we want to go back and examine the thought process that went into that behavior, because it wasn't real rational. Identification and debriefing of past and future high-risk situations. What really ticks you off? And how do we deal with it? What ticks you off? What are the thoughts about that situation that lead you to getting angry? Can we work with any of those to make them less angering? And what may happen in the future that might tick you off? And how can you decompress or calm down so you can think more rationally about what's going on? This is cognitive behavioral therapy, rational emotive behavior therapy, or dialectical behavior therapy. Notice how all of them have behavior in there. Encouragement and review of outside implementation of skills. You tried it. How did it work for you? And practice of new skills within sessions. So in summary, we look at what causes the behavior and what rewards it. We provide alternative methods for either dealing with our emotions or alternative behaviors. We examine at the thought processes that led to the behaviors, identify how this has occurred in the past, how it might occur in the future, and develop a relapse prevention plan, basically. It's important to discuss, review, and reformulate the patient's goals for treatment periodically. What was important 3 months ago may not be so important now. You may have that covered. Talk to them. You think we got this covered? Do we need to move on to something else? Can you be discharged? What's going on? It's important to keep monitoring the frequency, intensity, and duration of the target behavior, whether that be drug use, anxiety, depression, anger. That'll give you an idea about when we might be moving into an upswing. Because we all go through cycles where things are calm and okay, and then certain times of year for a lot of people, especially around the holidays, there's an upsurgence in negative behaviors. Monitor for dysfunctional substitute behaviors. Well, you may not be using crack, but now you're abusing pain pills. Or you're spending money like you own your own printing press. Or you're gambling all the time. We can substitute addictions. We can substitute negative behaviors that make us feel good for other negative behaviors that make us feel good. Monitor general functioning. Explore positive and negative consequences of all of the behaviors. Just continue to have the person ask themselves, what's the benefit? Explore the relationship between their emotions or their affect and the behaviors they engage in. Are there certain behaviors or certain ruts that you get into if you're depressed or in a funk? Well, if those are behaviors associated with being in a funk, then we need to not do those the next time you're in the funk. For example, a lot of people, when they get really depressed, don't get out of bed, or they don't leave their house, or they're in their jammies all day long. These are easy things that we can change that tells the person, or the person's body, the person's circadian rhythms that, hey, we're not going to stay in bed all day. And we know that helping people maintain a stable biological clock helps them feel less depressed and less tired all the time. Provide feedback on objective collateral information. If Jim comes in and he smells like alcohol and looks like he hasn't slept in 3 days, even if he thinks he looks all that and, you know, he rinsed his mouth out with scope, you might want to call him on it and say, you know, Jim Bob, you reek of alcohol and you look like you've been at the bar for 3 days. See what's going on. And then set the agenda for the session. Cognitive behavioral therapy is very goal-directed. Don't just kind of start off and do this free association thing. There are goals in mind, and if other sort of paths come up, you always need to relate it back to the first goal. Make process comments as indicated. Help clients identify their thought processes that led to their behaviors. Discuss advantages and disadvantages of their goals. Explore the patient's ambivalence about change, because there is some. Meet resistance with exploration and a problem-solving approach. I don't need to stop drinking. I'm not going to stop drinking. Okay. Well, let's look at what would happen if you did stop drinking, or why these other people are saying that you have a problem drinking. Let's explore that and figure out what we can do to try to help you out here. Support a patient's efforts to do the next right thing. They're not always going to succeed, but if they try. Assess their level of family support. Explain to them the distinction between a slip and a relapse. This is true for mood disorders as well as addictions. A slip is a one-time thing. A relapse is that slippery slope and you're down in the mud. And it goes on and on. Either way, generally there was stuff leading up to it. You weren't taking care of yourself. You were not using the healthy self-care skills. Something had changed which led to the slip or the relapse. And it's important, with the patient's permission, to include family members or significant others. That way they have supportive people in with them to provide them, you know, attaboys when the office is closed. In summary, CBT is useful in most situations with patients who are not actively psychotic or delusional. It focuses on how the past is impacting the person in the present and helps the person examine irrational, often learned beliefs and address them with changes in the way they think, alternate coping skills, and alternate behaviors.